Hello, good evening everyone. Myself Dr. Bhunesh. I'll be taking the few portions on prosthetics aspects. So first we'll start with the complete denture one. So in today's session, I will deal few aspects and basics concepts in the complete denture. On later classes, I'll be dealing on the fixed partial denture and on the removable partial dentures. So first we'll see about lingual sulcus. Why lingual sulcus is of major importance? It is mainly importance both in the clinical aspect as well as your exam point of view, because most of the questions will relate in the lingual sulcus region. Either they will point in the anterior lingual sulcus region, or sometimes they will ask about in the mylohyoid region, which forms the middle part of your lingual sulcus region. And major questions will be from the posterior aspect of your lingual sulcus, that is the posterior lingual sulcus, which has the retromylohyoid curtain, retromolar pad, retromolar papilla, and so on. So first with the anterior lingual sulcus, that is this dark brown band forms your anterior lingual sulcus. This green band will forms the middle lingual sulcus, and this posterior portion forms this posterior lingual sulcus. So this anterior lingual sulcus, if you see, it will extend from the lingual frenum to the pre-mylohyoid fossa, where the mylohyoid curves below this sulcus. So this region where I'm showing the pointer, you'll have this mylohyoid ridge and muscle attachment. So this region forms your middle portion of your lingual sulcus. So the middle lingual sulcus will extend from the pre-mylohyoid fossa region to the distal end of this mylohyoid ridge. So the posterior part of the posterior lingual sulcus will extend from this portion and ends where your retromylohyoid curtain falls. So when you see clinically, this is where your anterior lingual sulcus will start from your lingual frenum, will extend till this pre-mylohyoid fossa, and middle will extend from here till this region, till the mylohyoid ridge where it ends. From here, the rest all continues towards your posterior lingual sulcus region. So this posterior lingual sulcus region is called, or it forms this lateral throat form, which gives a key point in suction when you're fabricating your mandibular complete denture. So this lateral throat form has been classified depending on what level your denture can extend, which means what level your sulcus depth is there. So this sulcus depth, whether it is in this level or little bit lower, or it is like completely deep, depending on this, the lateral throat form has been classified by nail into class 1, class 2, and class 3. Is there any particular device to measure or record this lateral throat form? Means, to be frank, there is not a proper like marketed device which is available in markets to record or measure, but many devices has been fabricated by different staffs in various colleges to measure this lateral throat form. Those are like not manufactured by proper companies, but they used a particular scale which is like curved scale, or they use some u-shaped frame, which helps to measure this lateral throat form, because there is no point in measuring what is the that is required, because there is no clear cut guidelines. Like if the posterior lingual sulcus or depth is around like 5 you can get a good amount of retention. So there is not a clear cut guidelines or any like correlated factors, so there is no point in measuring the Instead, we can just classify it as class 1, class 2, and class 3, depending on what level it is extended. So we can attribute this amount of retention will be possible for such patient. So one more thing in this posterior lingual sulcus, first is this lateral throat form, and second one is this retromolar pad. So retromolar pad is a non-keratinized region which is present beyond this pear-shaped pad. Many people will think pear-shaped pad and retromolar pad are same, but both are not. So in anatomically, if you see, this region forms your retromylohyoid fossa. This is bounded anteriorly by the mylohyoid muscle, which extends from this myeloid region to this hyoid region. So laterally, this region laterally by a pear shaped pad. Then posterolaterally, this region we will have this superior constrictor muscle. Then posteromedially by your palatoglossus muscle, and medially by your tongue. So medially you have your tongue, then posteromedially by your palatoglossus muscle, then posterolaterally by your superior constrictor muscle, laterally by your pear-shaped pad, and it is bounded anteriorly by your mylohyoid muscle. So this region is called as your retromylohyoid fossa, which means a region that is retro means something behind. So region that is found retro to this mylohyoid region is your retromylohyoid fossa, where your lateral throat form is situated or located. Fine. So if someone gives this picture and they ask to identify or name this parts means, so this is your tongue, this is your ascending alveolar ridge. So point C, point B, and point A. Point A, if you see a thin line extending from this region, which is going towards top. So this is your pterygomandibular raphe, which extends posterior to your retromolar pad and extends towards your hamular region. So this point B, or a pad shaped marking, gives your retromolar pad, and point C, a round shape, this denotes your retromolar papilla. So if you see a patient with a dentate patients, you can easily identify next to your second molar, this region, a pear shaped pad will, if you palpate and see, you can actually note or like feel the pad shape, which is your pear shaped pad. Beyond this pear shaped pad forms your retromolar pad. You can see in both different clinical pictures. So why this retromolar pad and this lateral throat form is of more important? Because your lateral throat form will determine how much my denture will extend in the posterior lingual sulcus region. And this retromolar pad, which is located beyond your second molar or third molar, is important because once the teeth are like, once the patient becomes like completely edentulous, this retromolar pad becomes a prominent pad, and it should be covered when you are fabricating your complete denture. Your posterior extension, for your maxillary posterior extension, everyone will speak, it will extend till this PPS region, it will extend till the anterior vibrating, or it will found between the anterior vibrating line, posterior vibrating line. But when you speak about your mandibular denture, there will be many people who won't record this retromolar pad in their processes, and finally when you see that when they deliver the process, this won't stay properly. Why? Because see, this point, this BTC point denotes this retromolar pad. If this is not recorded, see in the next picture, there will be an air leak in this region, so the proper seal is not found or not formed in the process that was fabricated here. So if you record this retromolar pad or papilla in this fabricating of your mandibular complete denture, you will get a complete seal. If you fail to record in the processes fabrication, that is your impression stages, you will get an incomplete seal. And while recording this posterior region of your mandibular, when you're planning to take a mandibular secondary impression, there are two concepts, like whether you should record with the patient opening their mouth or closing their mouth. Few people suggest it is better to ask the patient to open their mouth and record, because when the patient open their mouth, this pterygomandibular raphe will be stretched or will become taut. So this extension or this point will be recorded properly. But a recent study suggests that it is not in every case. When the patient opens their mouth, this pterygomandibular raphe will become taut, mainly in case of an edentulous patients. So it is most suggested to record this region, that is this distal part of your mandibular denture region, impression region, to be recorded when the patient is closed, when the patient is having their mouth closed. Why? Because this retromolar retromolar pad will become an active when the patient's mouth is like closed. If it is open, this region will become or will be placed a little bit lower position, So you won't record this region in active form. So once the patient places the denture and closes this mouth, it will be the same thing will be in opposite direction, and so the air becomes leaked in this region, and again the complete seal won't be seen in that cases. So this lateral throat form can be classified into class 1, class 2 and class 3. So class 1 lateral throat form means no movement to the clinician's finger or a hand mirror when patient is protruding. So how this lateral throat form as such is recorded? We'll either place our index finger or will place the mouth mirror head over this lateral throat region, and will ask the patient to protrude the tongue very minimal, like they touch the tip of their tongue near their lower lip. So till that we'll ask the patient to protrude. We can't ask the patient to protrude completely the tongue. We will ask the patient to protrude their tongue to touch the tip of their lower lip. So that time, if no movement is seen to the clinician's finger or the hand mirror that was placed in that region, this throat form will be of class 1. In class 2, about half as long and narrow as a class 1 flange, or twice the length of a class 3. Basically, this class 2 is something between class 3 or class 2. So class 3 means when the clinician if he has placed his finger in this lateral throat region or the mirror and ask the patient to protrude the tongue, the complete finger comes out or the complete mirror is completely displaced, means this will be categorized as a class 3 kind of lateral throat form, which having a flange less than 2 to 3 mm in this region. So something that falls between this class 1 and class 3 is your class 2. So if a patient is having a class 1 kind of lateral throat form, generally the PPS will be of broad type. If a class 2 kind of lateral throat form is seen, the PPS will be of medium, or a class 3 means they will have a very narrow type of PPS. So these two are completely different. Your lateral throat form is seen in the posterior lingual sulcus region, lateral throat form, but your palatal throat form is seen in your soft palate region, where that is your junction of an hard and soft palate region. So your class 1 has a large and a normal in form with a relatively immovable band of resilient tissue that is 5 to 12 mm distal to the line drawn across the digital edge of the tuberosity. So just imagine this is your maxillary tuberosities and you're drawing a line. If you draw a line completely here, if any immovable band of tissue is present, if any immovable band of tissue is present from this point to this point, and if it is around like 5 to 12 mm, that gives your class 1 type of palatal throat form. In your class 2 it will be 3 to 5, in your class 3 also it will be 3 to 5. But where your class 1 and your class 2 and class 3 varies is that what angulation your posterior palatal throat forms is your gives the difference. In your class 2, this sloping will be around like 45-degree, but in your class 3 it will be more of an 70-degree. So ideally most of the people will be seen having a class 1 type of palatal throat form, but in class 3 usually accompanied when there is a more of resorbed condition, you will be having a class 3, or a very small palate you will be having a class 3 type. So your lateral throat form will have three different classes, where in your class 3 the lingual flange or the posterior lingual flange will be less than 2 to 3 mm, but in case of a palatal throat form the values will be 5 to 12 mm in a class 1. In a class 2 and class 3 it will be 3 to 5 mm only, but class 2 and class 3 varies in the degree at what they bend, that is 45-degree in class 2 and 70-degree in class 3. Mainly the confusions will come in the when they ask about lateral throat form and palatal throat form. So this is again the picture for your class 1 soft palate, class 2 soft palate and class 3 soft palate. So you can see how this region, that is A and B. A is your hard palate, B is your soft palate, and you can see how it bends. So in your class 3 it takes an abrupt turn giving around like 70-degree angulation. In class 2 it will be around like 45 degree. Class 1 it will be normal with having a 5 to 12 of extension of immovable parts of your soft palate region. So with having this kind of soft palate, it will guide us to record the proper posterior palatal seal region. So your posterior palatal seal as such, it is your pterygomaxillary seal along with the posterior seal. So your pterygomaxillary seal will extend from the distobuccal region of your maxillary tuberosity. So this is your maxillary tuberosity. The seal will extend from distobuccal region and it will end here. This is your pterygomaxillary seal, and your postdam or posterior seal will be formed in the soft palate region, which will be given by your posterior vibrating line and your anterior vibrating line. So if someone questions you like how will you mark your posterior vibrating line or anterior vibrating line, even if you Google, they will easily give you your anterior vibrating line is formed 3 to 5 anterior to the posterior vibrating line. Posterior vibrating line is formed by joining your both the hamelar notches, and it will be marked with the help of this hematoxylin or eosin pencil. Many things will be given. So, but the main problem or main question that arises is like, so these are the components for your posterior palatal seal. Your junction between hard and soft palate, posterior nasal spine, anterior vibrating line, posterior vibrating line, fovea palatine. Most of the questions will revolve around like the location of this fovea palatine. Majority of the subjects, that is around like 66 percentage, had fovea palatine anterior to the anterior vibrating line. So this is your anterior vibrating line. Majority of the people had this fovea palatine anterior to this, around like 66 percentage. According to a study done by Dr. Lai, the fovea palatine is located around 1 to 1.3 anterior to this anterior vibrating line. But in another study, it is found it is around like 2.4 anterior to the anterior vibrating line, but it is located within the soft palate. So the questions will come like how far or where is the location of your fovea palatine, whether it is anterior to the anterior vibrating line or between the anterior vibrating line, posterior vibrating line, or behind the posterior vibrating line. So more recently accepted thing is your fovea palatine is always located in anterior to your anterior vibrating line. But when they ask whether it is located in soft palate or hard palate, most answer should be towards your soft palate, because these anatomical landmarks, mainly this fovea palatine, is this anatomical landmark is not stable. It varies from person to person, so we can't pinpoint and give this is where it is located. Since there is a huge number of variation in the location of this fovea palatine, it is better to take a study where they would have like recorded this fovea palatine in n number of persons, and the most commonly accepted is like having this fovea palatine anterior to the anterior vibrating line around like 66 percentage. If they ask how much it is located, few study quote it is around like 1.31 and few quote it is around like 2.44 mm. So the main function or why they gave this PPS, the posterior palatal seal, is like to diminish the gag for the patient. If this PPS is not recorded, if without recording, you won't know whether you will extend beyond the PPS or you will fall short of PPS. If the denture base extension is short of PPS, obviously it won't stay. If you give the posterior border of your denture, maxillary denture in the hard palate, you won't have any posterior seal, so obviously your denture will fall back. Or without determining the proper extension of PPS, if you extend it completely beyond, patient will start gagging. So your PPS recording should be important to diminish the gag for the patient. And compensation of polymerization shrinkage. So when you see, there will be a polymerization shrinkage when you process with the heat cured material. So in your mandibular denture, this polymerization shrinkage will be compensated in your alveolar lingual sulcus, that is where your lateral throat form, the denture extension in your middle and lateral throat form region, there you generally will have a bulk of material, so it compensates for your polymerization shrinkage in mandibular denture. In your maxillary denture, the main bulk is located in the PPS region with the having a proper post damming and all. The bulk will be more in that region, so it will compensate for the shrinkage. And By adding more material, it eventually strengthens your maxillary denture by adding a bulk to it, and this will decrease the force on the ridge. When the patient bites, all the force gets concentrated to the center, or it concentrates towards the like posterolateral region. So the force on the ridge is like completely diminished. So the main function of PPS is to diminish gag, decrease the force on ridge, compensate the polymerization shrinkage, and strengthen the maxillary denture by adding a good amount of bulk. So how to identify this posterior palatal seal region? By either palpating, using you have your like instrument to locate your Hamlot notch, or to locate your vibrating line with the help of your T-burn issue. Then phonation method can be practiced, and nose blow method, that is your Valsalva maneuver, and your anatomic landmark. But there is many controversies in this anatomic landmark, that is your fovea platinae, because you have seen the study giving a result of various numbers in location of the fovea palatine, how much far before your anterior vibrating line and all. So to register or to record this posterior palatal seal, you have an impression technique or a scraping technique. Scraping technique is done generally in lab side, whether like even you record a proper posterior palatal seal, lab technicians will generally scrape a little bit, give a depth by giving a dam and giving their posterior palatal seal. But in impression, you can record using a low fusing compound, or a heavy or a very heavy consistency elastomer, or an impression using your wax. So so all this impression techniques everyone would have read, it is given everywhere. But this scraping technique, if some question arises means, there are around like 9 different types of scraping method. A few I have listed here. The PPS designs with a cross sectional view depicted in bags. So this figure 4.8, this is a single bead of scraping. This technique was given by Boucher and Bernard Levin class 3 technique, where he gave two two parts of scraping. So the posterior most line scraping will have a V shaped, and the anterior vibrating line depicting will have a prominent V type of scraping. So one more Bernard and Levin PPS designed for a class 1 and class 2 soft palate. It has a square type of cross sectional scraping. Then Swenson technique, where he gave a butterfly type of scraping type, and Kalmany technique, where a butterfly with a bead extension in the scraping, and Pounds technique and a Winkler's technique for PPS designs, and a Silverman's technique and Kapoor technique. Kapoor's technique is most commonly followed in the lab technicians nowadays, but to be with book wise means we will follow this butterfly technique or the Swenson's technique in the college scenarios. So we have seen from the lingual sulcus, bilingual sulcus, what is the importance of lingual sulcus, your antelingual sulcus, middle lingual sulcus, and posterior lingual sulcus. Why posterior lingual sulcus is of more importance? Because of these two things, your retromolar pad and your lateral throat form. What is the classification for your lateral throat form, and where it is exactly located anatomically? Because when you start imagining, because you won't see these things that often when you do a denture for a patient and all, but when you see more of like anatomical pictures, you can visualize or imagine, and you won't go wrong when you're answering certain questions. Then this pterygomandibular raphe, retromolar pad, retromolar papilla, the crest of ridge. What is your pear-shaped pad, and where it is exactly located? It is located in front of your retromolar pad. And what is the importance of recording this retromolar pad when you're taking impression, when you're taking a secondary impression for your mandibular denture? Then what is the classification of your lateral throat form? What is the classification of your palatal throat form? And where you will go wrong when they ask about like what is the angulation for your class 2 palatal throat form, it should be 45 degree. And what is the relative immovable band of resilient tissue distance, if they ask, it should be 5 to 12 distal to the line drawn joining the tuberosities in your class 1. It will be 3 to 5 in both class 2 and class 3. Then your PPS, your anterior vibrating line, posterior vibrating line, Hamler notch, And where the question generally revolves is your phobia palate, where it is exactly located, whether it is located in soft palate or hard palate, and how much anterior to anterior vibrating line it is located, and what are the functions of your posterior palatal seal region, how it is like located, how it is registered. You can register using your impression technique like fluid wax technique. Many more techniques are there, but if they ask, they might ask in the scraping technique, what are the different types that are scraped or that was followed initially. Swenson technique, Calmoni technique, Pounds technique, Silverman's technique, everything. Now coming on to your mandibular movement. So your mandible as such can move in three different axes. That is, if the mandible moves in this plane, if your mandible just comes forward, that is your horizontal plane. If the mandible, if you turn your mandible towards left or towards right, that is you are moving your mandible in a vertical axis. Then sagittal axis, where when you're turning your mandible towards your right, your working side condyle will be in a sagittal axis, in a vertical axis, but your non-working side will undergo a movement of your sagittal axis. So the most common movements that are for that you can do with your like mandible movements is your hinge movement, that is your opening and closing, protrusive movement, and lateral movement. So this hinge movement where, so this is your horizontal axis. So when you're opening and closing, your mandible will move only in your, only will give your hinge movement, that is your opening and closing, which occurs in your horizontal axis. So when the patient is opening his mandible, your condyle will rotate without translation. So your condyle will just rotate around like 12 degrees. With the 12 degrees, your this region, your lower anterior teeth will open around like 22 to 21 mm. So if the angulation or the rotation degree crosses more than 12 degrees, that is if it reaches around like 13 to 14 degrees of rotation, from just plain rotation, your mandible undergo translation. It will follow your temporomandibular joint, that is your, it will follow your glenoid fossa, and with it will translate towards front. So that will be your hinge movement. So to start a protrusive movement, your mandible should complete the rotation of 12-degree, then it should start translating, which gives your protrusive movement. And a lateral movement, it is completely different when you compare with this hinge and protrusive movement. So imagine, generally imagine the movements if they are speaking about lateral by looking at under the base of the skull. So if you see, if imagine the mandible is moving towards right, so when the mandible is moving towards right, okay, so more mandible is moving towards this direction, towards your right side, the working side condyle will be your right side condyle. The non-working side or your balancing side or an orbiting side, whatever the name, that will be your left side condyle. So why we need to see the differences? Just your mandible going to move, then where is the difference? When you keenly notice, see, if the mandible is turning towards this side, is there any obstruction for this portion of your condyle? Nothing, because it is a free end, it doesn't have any obstruction. But when you see on the non-working side, it will get obstructed to the base of your skull or this region where it is connected. This process is called as entoglenoid process. Similarly, when this mandible is moving towards left, this becomes the working side condyle, this will become the non-working side condyle, and this region, the entoglenoid process here, will stop or will put a hamper for its movement. So this working side and non-working side condyle dealing is of something important. So then most of the questions will be around like Bennett angle, Bennett movement, Bennett shift. So Bennett movement is nothing but your working side condyle, or if the movement here is right side, then your Bennett movement is towards right side. But where will you note your Bennett angle? Bennett angle will be noted in your non-working side. It won't be noted in your working side because this side it is a free end. You don't have any like proper bony stoppage or any other stoppage other than your muscle. You don't have any proper blockade over that to stop or give an angulation. So to give it get an angle for your Bennett angle, it is on your non-working side, but your Bennett movement will be in your working side. So imagine this is your entoglenoid process. This is where your condyle was located. Since the mandible is moving, it will translate or it will undergo Bennett shift like immediate side shift or recurrent side shift and all. It will move. So the angle formed when the condyle is without moving, it will draw a straight line. So now the condyle is moved till here. So the angle traveled or angle it has like moved or angle it has like rotated because of your mandibular movement. So that angle is your Bennett angle. So there is one more angle that is generally dealt in prosto, that is your Fisher angle. So this is nothing but an angle formed between the protrusive condylar path and your lateral condylar path. So when the condyle is like protruding, it will start from moving from here to here. Okay. So this is your protrusive condylar path. See, which will curve and move straightly. But when you're going with a sagittal lateral condylar path, it will take a direction and go. So this angle between your protrusive condylar path and your lateral condylar path is called as your Fisher angle, and mostly your Fisher angle will be having a mean between both the condyles of having a 5 degrees, but your Bennett angle will be something about 15 degrees around. It will vary from 15 to 20 or sometimes 25 depending on the race of the people, like which region. Your Afro-American or your African people will have a Bennett angle of more. Your Indian population will be having around like 20 degrees, but an American population will be having on like 25 degrees. So it varies from different races. So here we saw about your mandibular movements, which happens in horizontal axis, vertical axis, and sagittal axis. Hinge movements, till what degree you will have your hinge movement, beyond to which degree you will have your protrusive movement, and what are the lateral movements that will happen. So your lateral movement, you have your working side condyle, your non-working side or your balancing side or your orbiting condyle. Why this orbiting condyle or your non-working side condyle is of importance? Because of the obstruction given by the entoglenoid process. Now coming on to these two pictures. So the first picture gives one different concept and your second gives you another different concept. So the first one is your Silverman's closest speaking space. As the term itself, it completely denotes the space which is produced when you're pronouncing ch, s and j. So when you spell these three words or letters, your maxillary teeth or mandibular teeth will come to a very near position, but it won't contact. When you tell S, when you tell S or J, your maxillary teeth and mandibular teeth, mainly your anteriors, it won't contact, but it will come to a very closest portion. So that is called as your closest speaking space, which was given by Silverman. The other one is your freeway space. So freeway space is nothing but the difference of your vertical dimension at rest or vertical dimension at occlusion. So this vertical freeway space is the difference, which will be around like 2 to 4 mm, but your Silverman's speaking space, it generally varies. It varies from it can be either 1 mm or it can be either 4 mm, 5 mm. Maximum it can be around like 10 mm. That is your Silverman's closest speaking space. So this space indicates the vertical dimension of your patient. In an ideal case, the lower incisor should almost touch the palatal surface of your upper incisor. Increase in the freeway space, that is here, increase in the freeway space between your upper and lower incisor indicates an inadequate vertical dimension. So just imagine if this is around like 2 to 4 mm, So if this 2 to 4 mm is lost and this region is completely taken by your lower rim or upper rim, then there is an increased vertical dimension or increased VDO or increased vertical dimension of occlusion. This is when the freeway space is less. Here in Silverman closest speaking space, a decrease in the closest speaking space will indicate an excessive vertical dimension at occlusion. So both are different concept or both are completely opposite. If the freeway space is less means there is an increased vertical dimension at occlusion. If the closest speaking space is less or decreased means there is an excessive vertical dimension at occlusion. So be clear with these two things. Then most commonly asked questions will be around this post insertion problems, like after patient has wear the denture and gone, so what are the complaints the patient will be having. So most of the questions will be like patient is having this ulcer or like sore spot over this palate region or over the ridge region after 72 hours of like wearing the denture. So what could be the reason? So there are like many different reasons. I have listed few. So if the problem is soreness on the slope of the ridge, see the difference. The soreness will happen on the slope of the ridge or on the crest of the ridge. If it happens on the slope of the ridge, the main cause will be deflective occlusal contact, resulting in shifting of the bases. If the soreness is happening in the slopes means the occlusion is not proper, so it is like deflecting the denture. So once the denture is trying to deflect or the base of the denture is trying to shift over your residual ridge, it will have a problem over the borders, so resulting in the soreness in the slopes of the residual alveolar ridge. If the soreness is seen in the crest of the ridge, it is directly you can say it is because of increased VD. And how it will be clinically looking is like when you see the patient's ridge, exactly on the crest of the ridge there will be many minute red dots, which is like evenly like dispersed in all over the ridge region. That is directly indicating there is an increased VD, or there is a generalized soreness in the basal seat region, or instead of sores it is more of an ulcer, painful ulcer. All three will direct only one thing, it is towards your increased vertical dimension. If there is a burning sensation in the anterior palate region of the patients wearing a new dentures, that is the cause can be inadequate relief in the incisive papilla. Numbness or a tingling sensation in the anterior one third of palate, particularly in the anterior one third of palate means overextension in the anterior lingual border. When the patient or the person is smiling and the denture becomes loose means the buccal frenum is like not relieved properly. The loosening of upper denture while opening the mouth means excessive thickness in the distal buccal flange, mainly in your like buccal and your mainly in your buccal flange the thickness is more. So in that cases reduce the thickness completely, your denture won't become loose. And if the patient turns or like the patient moves his mandible and your upper denture falls means then there is a problem, there is an interference with the coronoid process. When the patient moves the mandible towards side and your upper denture falls means there is an interference with the coronoid process. Then difficulty while swallowing means the where we were dealing right in the initial of this session, we were dealing about the lingual flange that is in your lateral throat form. So there if the patient is having difficulty while swallowing means there is an overextension in the lingual flange region. Then having a pain and soreness during chewing means there is a deflective occlusal context. Mucosal irritation means overextension of your denture borders. Epilis fissuratum or any fissured thing if you see in the oral mucosa, that is mainly because of your ill-fitting denture or a sharp margins or your overextended dentures. Papillary hyperplasia generally, if you see any palatal region having a small hyperplastic region with the papillary nodules means it is mainly because of your candida albicans or candida lesions. If the patient is not maintaining the denture hygiene properly, it will result in a papillary hyperplastic pain. And one more important thing is like giving a clicking noise during the teeth contacts. If I don't know if you have noticed, if you are given a patient a increased VD kind of dentures, and ask the patient to chew or bite over the dentures, and if you keep your ear near their mouth and just listen means there will be a more like a clicking kind of noise over the teeth region, like more of a teeth to teeth contact sound will be seen. That is high causage is because of your increased vertical dimension. And tight denture becomes loose during your usage means the occlusion is not balanced or proper. Having cheek biting means insufficient horizontal overlap. If your posterior teeth arrangement, if it's like goes out of arch, if it goes either towards right side, then you'll get a cheek bite. If it goes towards your left side, that it comes towards your tongue region, you'll have a tongue biting and all. So these are the most common post insertion problems. Main question will be on like when you have an increased VD in your post insertion problems, what all the things can be noticed, like soreness on the crest of the ridge or fleeting painful ulcers. So now we'll discuss few of the questions. So the first question, the masseteric notch in a distobuccal corner of a mandible denture is due to, the options will be action of buccinator or masseter, action of masseter on buccinator, palatoglossus on buccinator, superior constrictor, or masseter. So whenever you're planning or when you're trying to answer a question, try, even if you're like sure shot, try to eliminate the other answer. If four options are given means try to eliminate by having a proper reason to eliminate all three, then you choose. If it is not a direct like or a, if it is not a question that is having a decimal numbers, if they ask like what should be the powder ratio, powder liquid ratio for like your heat cure or cold cure, that will be more of a decibel based values so that you can have a direct answer. But in such case, or if they give a scenario, try to eliminate other options, then you arrive at your answers. So in this case, the question, if you read properly, it is on masseteric notch, distobuccal corner of your mandibular denture. So in your mandibular denture, towards your buccal side of the distal region, you will have a masseteric notch. So this portion, this depression is your, this is your distobuccal region. This is your masseteric notch, which is formed. How it is formed? So when you see, this is your mandible and your masseter will origin from the zygomatic arch and the maxillary process of zygomatic mode and gets inserted into the ramus or the coronoid process of your, it will insert into the coronoid process and the ramus of your mandible. But when you take your buccinator, it will extend from this region and it will fall over this, or it will cover your masseter and runs along your body of your mandible. So the masseter will be inside and your buccinator will be outside. So it will be mainly because your action of your masseter on buccinator, the masseteric notch in the distobuccal corners, the mandibular denture is mainly because of your masseter on the buccinator. So this masseteric notch, how to record this properly means instruct the patient to open the mouth wide, then close against the resting force of your finger. So opening wide will activate the muscles of pterygomandibular raphe by stretching, thereby defines the most distal most region. Instructing the patient to close against the finger on the tray handle causes the masseter muscle to contract and push against the medially situated buccinator muscle. So this is your masseteric notch, or this is your masseteric notch. If this region gives your masseteric notch means you will have your buccinator running, then over which will be covered by your buccinator. So the answer for the masseteric notch will be by the action of masseter on the buccinator. So PPS anatomically. So PPS anatomically means they are asking what two factors that will contribute for your PPS. You have your pterygomaxillary notches, that is this region, your pterygomaxillary notch or your hamelar notch. Then you have your fovea palatine, you have your posterior nasal spine, pterygomaxillary raphe, or posterior limit of palatine bone. If you see this posterior limit of palatine bone and the posterior nasal spine are same, but if you see your posterior nasal spine will end somewhere here, which gives the cupid bow shape. So you won't extend your denture only completely till here. So you can eliminate option D and option B. Now the remaining two are your pterygomaxillary raphe and fovea palatine. So pterygomaxillary raphe and your maxillary tuberosity will be in same region, so it will be located only here, but this region they haven't mentioned, so you can easily eliminate option C also. So the PPS anatomically, if they ask, it is your pterygomaxillary notches and your fovea palatine, which will be generally located in the soft palate. So the distal palatal termination of your maxillary complete denture base is dictated by, there are like four different options. You have your maxillary torus, tuberosity, fovea palatini, vibrating line. So in this case, your maxillary torus doesn't determine your distal palatal extension. Generally, your tori will be something here. If you are giving a denture for that patient, means you will give a relief for your maxillary torus, but you won't mark it as a distal palatal extension or a termination. So remove this option. Then you have your tuberosity. Yes, tuberosities will give a distal palatal termination, but the most apt when compared all three is your vibrating line. If in this question, if they have mentioned instead of this PNS, if they have given vibrating line, your answer will directly go to pterygomaxillary notches and vibrating line. But since there was no vibrating line, the closest answer here is fovea palatine. So here, than fovea palatine, you have a vibrating line, which is like more apt answer. So here you should choose your vibrating line as a distal palatal termination of your maxillary complete denture base. Then your anterior vibrating line is located. So this will be your this cupid bow shape because you have your posterior nasal spine ending here. So your anterior vibrating line will be located always on a soft palate tissue region. It won't locate on the hot palate. In hot palate, it might start, but when you mark properly, means you will mark behind this hot palate region. That is your anterior vibrating line. And you can't be confused like whether it will be on soft palate or hard palate. Pakka, it will be on your soft palate tissue region only. Imagine if you're placing your denture portion in your like hard palate region, you won't get a proper seal. If the postam region is placed in your soft palate region only, you will have that. When you have something placed over your soft tissue region, you will have a suction. But when you neglect or placed over a hard tissue region, you won't have any suction or retention, anything. So your anterior vibrating line will be always located on your soft palatal tissue. So the Bennett movement of mandible. So as I said before, the Bennett movement means a lateral bodily movement of your mandible. If you are moving your mandible towards right, then the Bennett movement is your in your right side. So Bennett movement is not just a condylar rotation or a protrusive movement or edge to edge occlusion. So protrusive movement is different, condylar rotation is different, but lateral bodily movement of your mandible is your Bennett movement. So this picture, they are trying to record something. So what if you keenly notice means something they are planning, they are recording with the help of having a fork. This is called as a bite fork. So with this bite fork, they are recording something that is your kinematic face bow. So your kinematic face bow as such looks similarly. So the use of kinematic face bow is contraindicated in the edentulous patients because it has to be used on the mandibular ridge. Recording base may be unstable on the edentulous patient. Movement of bases may lead to inaccuracy in recording hinge axis, all the above. So when you see kinematic face bow, your normal or your arbitrary face bow to record your like orientation jaw relation of your maxilla, mainly we will use an arbitrary phase bow for an edentulous patient, but we'll use your kinematic phase bow for a dentulous patient because the values obtained from the kinematic phase bow will be more precise and proper. So that amount of accuracy should be needed when you're rehabilitating your dentulous patient. So that amount of accuracy is not that much required when you're rehabilitating your completely edentulous patient. So and what are the problems will happen because when you're giving a kinematic phase bow transfer, it will be resting or it they'll have a mandibular clutches like how you have your cap splint. It will have a cap splint that will be placed over your mandibular teeth, so it will be more stable. But in the case of your mandibular ridge, you won't have a proper suction when it is completely like edentulous and sort of more of resorbed kind. It won't be placed properly. So in that cases, if you use it over your mandibular ridge, it won't be stable, or the recording base won't be that stable in your edentulous mandibular ridge region. So it will tend to move. So because of this movement, the value recorded here. If the movement here is like, if the base here is like not proper or stable, the value recorded here will be completely different. So there is no use of using a kinematic phase bow and locating the hinge axis also. So the use of kinematic phase bow is contraindicated in edentulous patient because of all the three reasons that is listed. So this is again the other view of your kinematic phase bow and how it records. When establishing a balanced occlusion, lingual cusp of maxillary posterior teeth on working side should contact what? So just imagine, this is the working side, means my mandible is like moving towards left side. So this becomes my working side. This becomes my, when I'm moving my mandible towards left, my left becomes my working side. My other side, that is the right side, becomes my non-working side. So the question here is, when establishing a balanced occlusion, you have given a balanced occlusion for patient, the lingual cusp of the maxillary posterior teeth on non-working side. So there's meaning about this non-working side or your balancing side, the lingual cusp of maxillary posterior, that is your palatal cusp of maxillary posterior, will contact which side? So when I'm moving this portion towards, so the contact for my maxillary lingual cusp will happen with my mandibular buccal cusp. So that is your facial cusp of your mandibular posterior, and the inclines will be here for this will. So when you have a teeth, this will be your lingual incline and this will be your buccal incline. So here the contact will happen in my lingual incline, will have a contact with the buccal incline of my maxillary posterior lingual cusp. So first draw, whenever you are in doubt, take a paper and draw like how your occlusion looks. Mainly you see like when you see from the posterior side, or when you see the occlusion, lingual occlusion from behind an articulator, imagine that diagram whenever you are imagining such questions. Then you will be able to clearly answer. So here they are telling in a non-working side, that is your balancing side, the lingual cusp of maxillary posterior teeth, it will contact which, that is your lingual incline of the facial cusp of your mandibular posterior teeth. Next one, a high occlusal contact occurs in a balancing position between the lingual cusp of maxillary first molar and buccal cusp of mandibular first molar. To eliminate this, which surface should be reduced? So the question here is again a balancing position between the maxillary first molar lingual cusp and the buccal cusp of mandibular first molar. So when you see your maxillary first molar and your mandibular first molar, these two cusp, those are called as your stamp cusp, or the cusp that gives a proper occlusion. So these two stamp cusps should not be trimmed at any cost. So we should try to save, and we should try the other interfering cusp. But in this, when you see about the option, it is the either lingual cusp of a maxillary first molar or a buccal cusp of mandibular first molar. So when you see in all the things, there'll be either trimming both the cusp, lingual cusp and buccal cusp, or lingual cusp of a maxillary first molar with milling at the time of denture insertion. You should, these changes should be made either during the trying stage or during a lab remount stage. It shouldn't be done after insertion time. So these interferences should be corrected during your trial stage or your lab remount stage. So this option is completely eliminated. The lingual cusp of maxillary molar in centric and in occluding position. By removing one cusp alone, to remove this kind of high occlusal contact, means the contact what you established or what an anatomic teeth that you have given, it will be completely removed. So in that case, if you remove on both this stamp cusp, both the lingual cusp of the maxillary first molar and the buccal cusp of mandibular first molar, you will be reducing. See, if you're reducing only in one cusp, you will be reducing around like 0.5 mm. But if you evenly reduce in both the cusp, it will be around like 0.25 mm in lingual cusp of maxillary first molar and 0.25 mm in your buccal cusp of mandibular first molar. You can easily remove this eye contact that occurs between the balancing position. So these are the contacts that generally occurs during your lateral excursion your balancing side, that is your working, that is your non-working side or an orbiting side, the contacts will happen in the rule of bull and llb, buccal inclines of upper lingual cusp and lingual inclines of lower buccal cusp. This is called as mediotrusive or non-working inclines. Similarly, during the lateral excursion, the working side contacts will be of lingual inclines of upper buccal cusp and buccal inclines of lower lingual cusp. These are called as laterotrusive or working side inclines. So as I said, Bennett movement is the lateral bodily shift of your mandible. So your Bennett movement is a direct lateral shift of the mandible that occurs simultaneous with the direct with lateral mandibular excursion. Yes, the mandible shifts bodily completely towards left, and the mandible also will have a lateral excursive movements. When you take the other instance, direct lateral shift of mandible that occurs simultaneously with medial mandibular excursion means no. The medial mandibular excursion will, as I said, Bennett movement will be or will direct every time. Bennett movements means it is on the working side. So here, imagine if the movement is towards this side. So there will be a direct lateral side shift of mandible and along with lateral mandibular excursion. This medial mandibular excursion will happen in the non-working side, okay, where your Bennett angle is formed. This is on the non-working side. This doesn't correlate with your Bennett movement. Direct medial side shift, no. Your Bennett movement means direct lateral side shift. Direct lateral side shift with medial mandibular excursion, no. It will be direct lateral side shift with lateral mandibular excursion. Feeting painful sores over this ridge region or feeting painful sores are generally caused by, as we already discussed on the post insertion problems, the most common is your increased BD, that is your occluding face height being too great. To have a twist in the option, instead of having a direct answer like increased vertical dimension, they have given like occluding face height being too great. The maximum depression of the soft palate is recorded when the Frankfurt horizontal plane is 30° below the normal horizontal plane. Why 30° below? You can have it 10°, you can have it 60°, 80°. Because with various studies they have found when the head is tilted 30° below the horizontal plane, your posterior, that is your soft palate, will have a will move downwards and forwards, giving the maximum bend when in a complete active manner. So when the soft palate is like in a complete active manner, it will be recorded with the having a head tilt of 30°. So that is what we should be recording. So it is ideal when you're recording your posterior palatal seal, when you're taking a secondary impression, when you're planning to take a secondary impression, it is ideal to ask the patient to bend his or her head completely 30° downwards, so you will record your posterior palatal seal, that is your soft palate region, properly. So a resorption of mandible in old age happens centripetal, centrifugal anteriorly, centrifugal posteriorly. So the answer is centrifugal. Why? Because in maxilla, the resorption is always centripetal. That is, the resorption will happen towards the center. So the borders or the periphery will start resorbing initially, and so your maxilla will become smaller, smaller, smaller. But in your mandible, it is opposite, where your centrifugal kind of resorption happens, because where the lingual region will resorbs more faster. So when you see a properly resorbed maxillary and mandible, your mandible will be completely small, your maxilla will be completely small, your mandible will be completely large. So when the question is like resorption of maxilla in old age means it will be centripetal, that is towards the center. Resorption of mandible means it is centrifugal, that is away from the center. Balancing side contacts in natural teeth. So when you see this question, the term natural teeth is the key. So balancing side means when you're moving your mandible towards right. So when you're moving your mandible towards right means, when you're imagining in an edentulous patient, when you're moving your mandible towards right, your upper and lower teeth will have a contact. That time there is a high chances your non-working side will, the denture might lift. To prevent the lifting of denture over that region, you need a contact in that side also. But in the case of a natural teeth, why you need a balancing? There is no point in giving a balancing. And if the patient, by some way, if they are having a balancing contacts in a natural, patient is having complete set of natural teeth and he is moving his mandible towards right, that time if he has a contact in the left side also means, then the left side teeth will having a too much of problem. He will have too much of problem because there is no need of balancing in your natural dentition. And those contacts that happen in natural teeth condition, balancing side of, in your balancing contacts in natural teeth, those are called as interferences. So if these interferences are not corrected, it will start exerting the forces from the teeth to the PDL, and it will destruct the PDL completely. So the balancing side contacts in natural teeth doesn't improve muscle balance and all, doesn't provide a balanced occlusion, because there is no use of balanced occlusion in your natural teeth when it is completely stable. So the apt answer will be it destruct the PDL in the balancing side region. So this is the working side. So this is the working side contact means in natural teeth it shouldn't have any contacts. If it have any contacts in this side, then these are called as interferences. In a denture, yes, you need, if this is the working side means when you're moving your denture or a mandible towards this side means, this side it should balance or your denture will lift in the non-working side. When a patient with a complete denture complains of pain while swallowing and there is an overextension in the distolingual aspect, so this is the denture, this is the distolingual region. If the patient is having pain while swallowing means when he is trying to swallow, these muscles are getting activated, then the overextension in this region, it is mainly pricking or hampering which muscle. So the muscle involved is like superior constrictors, palatopharyngeus, palatoglossus, stylopharyngeus. So you don't have stylopharyngeus here, you don't have palatoglossus, you have palatoglossus but not in this region, you don't have palatopharyngeus. So the apt muscle, when they ask any muscular problem in the distolingual region means, directly you can choose it as superior constrictor. Mandibular ridge resorption causes, as I said, your mandibular ridge resorption will be of a centrifugal type, where your posterior regions or your postrolingual region will have a resorption. So eventually the posterior region will becomes widened, so the resorption will be more here. So initially the ridge would have been at this level. With the resorption, the crest of the ridge will slowly move towards buccal region, so giving a widened posterior ridge kind of look. Your mandibular ridge resorption causes widening of the posterior ridge region. So identify this articulator. So one image based question is like they will place such kind of different type of articulators and they will ask to identify. So this is not your hinge articulator. Mean value articulator is what you use in your preclinical time, your whip mix or HANA wide view. So this articulator is a HANA wide view type of articulator. Your whip mix articulator doesn't have this kind of like armamentarium or location and all. So the articulator that is placed here is your HANA wide view type of articulator. Identify the class of residual alveolar ridge. So this is the image given. So the residual alveolar ridge can be classified into 6 different types as class 1, class 2, class 3, class 4, class 5 and class 6 by Atwood. So class 1 is immediate pre-extraction, class 2 is post-extraction, class 3 is high well-rounded, class 4 is knife-edged, class 5 is low well-rounded, class 6 is resorb. So here they have extracted and the socket is like still there. So this is kind of an immediate post-extraction. So the class for this is class 2. Fine. So identify the instrument. So this is your face bow, but when you see there are like different types, you have your kinematic face bow, arbitrary fascia type face bow, arbitrary earpiece type of face bow. So here your kinematic face bow, previously I have shown how it looks. So this is how your kinematic face bow looks, which is entirely different. So this is your fascia type or an earpiece type of. So this is your arbitrary face bow. In arbitrary face bow, you have two types: fascia type and earpiece type. So if this is the earpiece which will go and sits inside your ear, instead of this, if they have placed this portion something in near your tragus region or in front of your tragus region, that will be your fascia type of face bow, which is not widely used. The most widely used is your arbitrary earpiece type of face bow. So coming on to identify this condition, there are like one clinical condition has been given. So whether it is Torre means no, Torre will be in your palatal region. Burning mouth syndrome, you can't identify directly. It is more of a clinical, not a clinical finding, more of a symptomatic finding. Like with the patient's symptom, like burning mouth and all, they will tell clinic key features. That is how you will find your burning mouth syndrome. Denture stomatitis, the patient is having denture, there will be more of papillary hyperplastic region. That will be your denture stomatitis. Epilis fissuratum means overextended denture in this region, that is in your buccal sulcus region, has resulted in a fissure type of epilis growth here. So this is your epilis fissuratum type of condition. So with this, part one of your session for this prostho class I have dealt. So in forthcoming classes, I'll be dealing on removable partial denture and your fixed partial denture. So any questions you can post. We will try to add in the upcoming classes.